We know that Prader-Willi syndrome provides a constellation of symptoms that we now come to realize are behaviors. We also know that Prader-Willi syndrome is determined by genetic factors. There are many different types of genetic factors that lead to the syndrome, but basically all of them produce very common behaviors. We know that Prader-Willi syndrome has cognitive and behavioral characteristics that are quite unique, and I call these all of my S's. First and foremost, they are very stubborn individuals. They are non-compliant, argumentative, they have tantrums and shutdowns. They are also very sneaky. They manipulate, they lie to escape punishment. They can be incredible storytellers. They confabulate huge whoppers. They can be very sticky, not only in their thinking, but also in their behavior. And that leads to what we call cognitive rigidity or inflexibility, perseveration, difficulty with transitions or changes. We also know that they have very adaptive behaviors. They are very attractive. Anybody who has seen some of the babies over in the YAP program will certainly agree that the blonde-haired, blue-eyed, round-faced babies are some of the most adorable children that you will ever see. And it happens to be these characteristics that absolutely latch on to us when they're infants, and those bonds endure for the remainder of their lives. They are also very engaging. A smile on their face will melt an iceberg. They are very lovable. They are very eager to please. They like to be in a routine, and they like to have a schedule. Many of them are very good at puzzles, which is really important because it provides excellent source of leisure skills for them. They also tolerate repetitive tasks, and this is very important also for thinking about vocational programming, because some of our folks will do things that other people won't, and they will do them very well and with good consistency. They can also be very caring toward pets and plants, and occasionally younger siblings. Now we're going to get back to a few more behavioral characteristics. They're also seekers. They acquire food, attention, stimulation, and they also like to collect and hoard. They are very self-centered, and this is what we call egocentrism. In addition, they have a very narrow point of view, restricted interests, and impaired judgment. And the judgment is impaired because they think of things only from their perspective, not necessarily the perspective of others. They are, above all, stress sensitive. They are insecure, they need plenty of reassurance, and they need to have a routine and a consistency. And one of the things that we talked about this morning was the importance of the infrastructure, and that is the environment. And they most definitely need to have all of these things in order to manage their stress. They're also sleepy. They're not only sleepy because they do require a lot of sleep, but they also tend to drift off and sleep at times that are not necessarily desirable. They also are slow in that they have developmental delays and learning disabilities, and also intellectual deficiency. And some of these traits lead to the maladaptive symptoms or behaviors that we see in Prader-Willi syndrome. Temper tantrums, shutdowns, aggression, property destruction, food acquisition resulting in theft, runaways, 911 calls, false accusations of abuse. Remember, I told you they were very good storytellers. Meltdowns or threats of harm, not only to themselves but to others, and also severe skin picking, which can result in self-injury. Now, one of the key factors in Prader-Willi syndrome is that the intellectual quotient, or what we call IQ, is lower than what we see in their typical age-matched peers. And we also know that intellectual efficiency does contribute to adaptability, and therefore is a big contributor to behavior. Mental retardation is defined as an IQ score of 70 or below as measured by a standardized psychological test. It also requires deficits in adaptive functioning, and the onset has to be before 18 years. And it should be very clear that almost all of our individuals with Prader-Willi syndrome meet these criteria. This is a normal distribution of IQ scores. And basically, an IQ of 100 is considered to be sort of the average. And what you see is that the number above 100 and the number below 100 are very equal. That's what makes it a normal curve. And when we look at those individuals with Prader-Willi syndrome, we see that they cluster somewhere between 60 and 70. And that's how they earn their diagnosis of mental retardation. But what I want to also bring to your attention is that the distribution of IQ scores is very similar to that normal bell curve that defines all of our intellectual abilities. And so what that means is that although they are fewer in number, there are individuals with Prader-Willi syndrome who function well within the normal range of intelligence. And also, there are those that are at the lower end of the intelligence spectrum. But I just want to give you this sort of an umbrella view of how the intellectual function is distributed across our individuals with Prader-Willi. Now, another characteristic that we see in Prader-Willi syndrome are learning disabilities. This is to be distinguished from intellectual deficiency because it has to do with patterns of function which are actually linked to the brain. And so today I wanted to take you to and show you where I work. I work here every day. I work inside the brain. In my trek to find out why people have the kinds of symptoms that they have and how their brains work differently to enable me to understand how I can explain this to other people so that they can provide environmental adaptations to help them function at their optimal potential. If you recall, Dr. Gurash talked about the hypothalamus, and then I also want to bring to your attention this big structure here. This is what we call the cortex. And this cortex is like a huge canopy that sort of is a protection because this is where our thinking and our problem solving and our reasoning capabilities are. Now, individuals, and this is not just true of individuals with Prader-Willi, but also true of all of us, there are left brain skills that enable us to do step-by-step processing that enable most of our speech and language functions. In almost everybody, even people who are left-handed, their speech center is on the left side of their brain. So there are very few of us who are truly in our right minds. The left brain skills are basically involved in speech and verbal communication. And so that is both the comprehension and production of speech, reading, which is an extension of language capabilities, and also logical thinking. Learning disorders of the left brain involve phonological disorders, articulation problems. And by the way, as I go through this, I'm sure that you will associate this to the individuals that you know and love with Prader-Willi syndrome because phonological problems are one of the most frequent kinds of difficulties. They're articulation disorders. Expressive language disorders also occur. That is, the inability to put your thoughts into words. Sometimes individuals have both difficulty putting their thoughts into their words as well as being able to understand what is said to them. And this is a far greater disability, and this is called a mixed receptive and expressive language problem. And then, of course, the one that we know well is dyslexia. It's a fairly common occurrence in the general population, and we do see it in our individuals with Prader-Willi as well. Now we're going to talk about right brain skills. The right brain is involved in what we call simultaneous processing. Whereas the left brain is more step-by-step, this is more holistic and involved in integrating various pieces of information that come at you all at once. The biggest deficit that is seen with right brain problems is called nonverbal language difficulties. And these are the abilities that people have to read between the lines. That would be the biggest kind of comprehension difficulty that they have. So they take things very, very literally. The other is that when they speak, they don't have a characteristic modulation in both the tone of their voice as well as the sort of cadence or rhythm of their voice. Individuals with right brain problems also have difficulties with time and space concepts. so that they literally use their verbal skills at times as sonar to basically sound out where they are in their environment. These are individuals that are very, very chatty. And we also know that the right brain is the repository for understanding of emotional valence to events that occur in our lives, so that the right brain processes information with the emotional valence attached to something so that the significance of it is more easily understood. So nonverbal learning disorders involve the faulty processing of nonverbal language skills. That individuals with these difficulties tend to be verbal but illogical. They can't read between the lines, and they don't see the big picture. They tend to be very focused on details, but they don't get the big idea. And they also have a variety of dyspraxias because their bodies are not well coordinated with their movements because they can't sort of manage their bodies through space. And this may account for some of the clumsiness that our individuals experience, but most certainly accounts for some of the coordination problems that we see in speech and language and deficits in adaptive functioning. So when we look at Prader-Willi syndrome, or individuals who have Prader-Willi syndrome, I like to see how they are different both by their intellectual endowment, whether there are learning disabilities present, and how these factors impinge upon their behavior. Now we also know that there is a very important variation that all of us possess called temperament. Temperament is one of those things that you can identify in newborn babies. It is one of the most resilient characteristics that human beings have, and temperament is not only the foundation of what makes us different one from another, that is our personality or sort of our unique stamp, but it also has been shown to be the cornerstone for understanding psychiatric disorders. For example, infants who display something called behavioral inhibition. You present a novel task to them and they shrink away from it or become irritable and fidgety. Those infants have a much higher possibility of developing anxiety problems later on, and certainly have an increased incidence of anxiety problems and depression as adults. On the other hand, individuals who are much more impulsive, more distractible, more inattentive, grow up to be kids who have those kind of difficulties, and they develop into adults who have similar problems. So we know that behavioral inhibition and impulsivity and aggression are temperamental factors that definitely are the hallmarks of psychiatric difficulties in adulthood. Temperament, as I mentioned, is unique contribution of personality traits. It's consistent upon the lifespan, and it is hereditary. So that these traits that I'm speaking of, if you have them as parents, you may very well pass them along to their children. And these temperamental characteristics, because they are sort of like those unique qualities that determine personality, they set the tone for interpersonal interaction. So, how does this goodness of fit happen? You look at goodness of fit when you're talking about babies and moms. We look at the characteristics that are all sort of brought together in the person. That would be their genetic endowment, their intellectual ability, whether there are any learning disabilities, and their temperament. And we also know that individuals with Prader-Willi syndrome are highly dependent upon their environment in order to be able to function to their optimal potential. And this is because they are so stress sensitive, and also because of their unique cluster of characteristics that require them to be so dependent upon what goes on around them. It is as if when the genetics were being sort of given out, that they didn't get that part of the gene that codes for adaptability in the face of environmental change. And so in order to help those individuals function optimally, we supply the environment. Now, when there is a good match between the person and the environment, everything goes rather smoothly. But unfortunately, sometimes there is a response from the environment to a given behavior which does the opposite. instead of helping the behavior or sort of adapting the environment to meet the behavioral problem, the environment actually delivers a response that causes the behavior to be exacerbated. And when that occurs, behavioral symptoms result. So we look at symptoms occurring when there is a mismatch between the person and environmental expectations. And here you see an example which I think typically happens in our individuals with Prader-Willi syndrome, where they have difficulties, but the environment is not endowed sufficiently to meet their needs, and so therefore there isn't a goodness of fit. This clearly happens a lot in school situations because they are unable to adapt the environment to meet the needs of the child. This happens sometimes in our homes, but we hope that through lectures such as these, it will arm you with the instruments out of the toolbox that you need to be able to craft an environment that will meet your child's needs. Now, we know that stress is one of those potent, noxious elements that does have a way of impacting on the person to cause trouble. And here's an example of stress basically causing the person to basically swell up so that the environmental needs are mismatched. I could do the same reverse slide for the environment because we know as parents and providers, you are basically the crafters of the environment for the child. And we also know from studies that have been done that as parents of individuals with Prader-Willi, you have much higher levels of stress than in any other disability or any other genetically determined problem. So it would be easy to see why stress would have such a huge impact on these types of mismatches, which then produce symptoms. So stress most definitely produces symptoms, both by causing the individual to have a problem because they can't adapt, and also because stress impacts upon the environment to cause the environment to either shrink or to not create the kind of responses that will address the problems adequately. We look at symptoms as increased intensity of typical Prader-Willi syndrome behaviors, abnormal Prader-Willi syndrome behaviors, or a pattern of abnormal thought, mood, and behavior that interferes with function over a specific time frame. So getting back to this familiar schematic, we have typically developmentally appropriate behavior, and in the late school age, early adolescent child, this is talking back. We have normal Prader-Willi syndrome behaviors, arguing, and we have abnormal behaviors when aggression or self-injury result. Psychiatric symptoms are of those changes in mood, thought, and behavior that we spoke of that are typically viewed as abnormal. These are the symptoms that typically result from a person-environment mismatch. And symptoms can be within all of these various groups. And I want to focus on two that are probably the most important in our syndrome. The first is the disruptive behavior disorders, of which we look at difficulty with attention, difficulty with behavior like oppositional behavior, difficulty with conduct problems, and also the one that is highly represented in both children as well as adolescents and adults would be the mood disorders. And those are disruptions of affective stability, that is, how the outward expression of a person's emotional regulation is called affect. Mood problems, which is how the individual defines their mood state. And typical mood difficulties that we see in our population are anxiety, depression. Dysthymia is a minor type of depression. Hypomania, which is a minor type of mania, and also mania. Depression is when you have low energy, you feel sad, you lose interest in things, you lose motivation, and sometimes can have complaints about body problems. When you are manic, you have exactly the opposite. You have increased desire to do things, increased energy, increased goal-directed behavior, and a pattern of euphoria, which is not consistent with the environment or events that occur in the environment. And then dysthymia and hypomania are sort of more modulated varieties of those two. Something else that we typically see a lot in individuals with Prader-Willi syndrome are obsessions. And some people consider the perseverative thought patterns that our individuals have as obsessional. It may not be that. It may be that we're just looking at that cognitive rigidity and labeling it as obsessive. And we also know that our folks do have compulsions, especially to collect and hoard things. I want to bring to your attention psychosis, because there are reports of increased symptoms of psychosis in our population. Almost always these are associated with the mood disorders that we see, either depression or mania. And psychosis has three major components: that of disordered thought, delusions, which is a fixed false belief, and that is to be distinguished from some of the whoppers that our folks tell, and also hallucinations, which are perceptual distortions. And I want to caution that these are observed not around sleep, because our folks with Prader-Willi syndrome do seem to have an increased risk of having sleep problems, and there are a variety of perceptual distortions that go along with those. Stereotypies are unusual mannerisms of movement that our individuals have a lot of. Could be eye rolling, could be blinking. Sometimes their picking can be considered as a stereotypy, and occasionally we see tics, which are abnormal, jerky kinds of movements. Now, we know that symptoms, patterns of symptoms, usually lead to evaluation, and that's where I come in. The psychiatric evaluation requires the doctor to delineate the nature of the symptoms, their duration, and their severity, which is the severity of level of impairment. That's the level of impairment factor, which is absolutely essential to making a diagnosis of a psychiatric problem. The psychiatrist should understand the context in which the symptoms appeared, and they should determine how the symptoms have previously been managed. A developmental history should be obtained to look at issues of temperament and developmental progression. Medical, educational, and social history should be obtained, and if there are data sources from each of those, then they should be acquired. Certainly, the person should be speaking with the medical team involved in the individual's care, and most certainly reviewing an IEP. A family psychiatric history is very important, and I'll discuss that in a minute. And a review of symptoms to determine something we call comorbidity. And what comorbidity means is just multiple problems that co-occur at the same time. Family psychiatric history is very important. It is one opportunity that the psychiatrist has to really take a look at the environment in which the child has been born and thrives. Families of individuals with Prader-Willi syndrome have more stress, so being able to gauge what that level of stress is, how it has affected the parents, how they've been able to rally and build their team, all of these things are involved in the evaluation. So it's not just so simple as doing a family genogram, which is displayed in this slide. We know that stress has a way of unmasking symptoms, and that stress can also unmask underlying vulnerabilities, and that is risk. And so we all know that we are a product of our genes. We know that we share many of the same genes with our family members. So being able to know what is in the family tree is enormously helpful to me to know how much of the individual is presenting with typical Prader-Willi syndrome behaviors, how much of this is related to Prader-Willi syndrome behaviors under stress, how much of this is related to the IQ and temperamental differences and learning disability differences, and how much of this is what happens when stress hits a family and underlying psychiatric vulnerabilities are disclosed. The evaluation of the child and adolescent, but this would apply for an adult that I would see, has to do with observing the interaction with others. When I have an individual who's in a group home, I almost always go to the group home because it gives me such a wonderful opportunity, again, to evaluate the environment. School visits, equally as important, because you need to understand what the individual is facing on a day-to-day basis. I interview the person with words, and if they have some of those expressive language problems that we talked about, I use play. And the mental status examination, just so you know that, when we're sort of sizing up a person, we actually have set criteria in our mind that we use to evaluate them. We look at appearance, demeanor, emotional expression, that we look at their thoughts, their feelings, their language capabilities, motor abilities, attention span, problem solving, and insight and judgment. And based upon all of this information, we are then able to put together what we call a formulation, which is exactly why did these symptoms occur. That is my goal. I have to say that we don't always have all of the pieces of the puzzle to be able to put together so nicely and neatly for families. But we do try to look at what the predisposing factors are, what the precipitating factors are, i.e. stress, what the perpetuating factors are, what is happening in the environment to either make those symptoms swell up or make them sort of recede, and what are the protective factors, how is this individual coping. We know that evaluation leads to a diagnosis, and the diagnostic formulation is looking at diagnostic possibilities. This is usually in the form of a rule out. Well, I think that there's depression, but I think I want to rule out something else, and we're going to do this in order to help you understand that, like further testing, further consultation, or further evaluation. Sometimes psychological testing, if it's not already been done by the school district, could be done by a neuropsychologist. That's extremely helpful for looking at learning disabilities. And also for developing a treatment plan, which should be presented to you, as well as a prognosis, which is what will happen if we do nothing, what will happen in the natural course of the disease, and what will happen if we do implement a treatment plan. The typical psychiatric diagnoses that we see include the disruptive behavior disorders, which are attention problems, oppositional behavior, and disruptive behavior, which is usually conduct difficulties. Anxiety disorders, because if you're thinking of a model, stress equals anxiety, that's a pretty good model to use. And anybody who is anxious and who continues under stress is extremely high risk for having a mood disorder. And the kinds of mood problems that we see in our population are sort of the worst cases that we've had the opportunity to work with over the years. I have been amazed at the number of small children and adolescents who present with mood disorders. And in a typical population, what you will see is the disruptive behavior disorders are well represented in that population. We've seen many individuals with mood problems. We talked about OCD, obsessive compulsive disorder. There are lots of obsessive and compulsive behaviors that are part of the syndrome. But truly meeting the criteria for the disorder, there really are probably more people being treated for OCD who have Prader-Willi syndrome that actually meet the criteria for it, which we'll talk about when we talk about medications. We mentioned tics, stereotypic movement disorders, those are the picking behaviors. Impulse control problems, we see lots of those. Those are many times related to stress. And fit the model for outrageous behaviors. Enuresis and disorders of elimination, and again, sleep disorders, as I mentioned. Everybody who has Prader-Willi syndrome, regardless of their IQ, they have what is called the Prader-Willi syndrome personality, and that is a bona fide diagnostic entity in DSM-4. And it is a medical disorder. It's a personality change secondary to a medical disorder, and the medical disorder is Prader-Willi syndrome. And the characteristics of the PWS personality are listed here. And those are basically all of those behavioral characteristics that we talked about, those symptoms with S's. Egocentrism, poor judgment, again because they're very egocentric, focused on themselves. They have difficulty taking another person's point of view. They're very rigid in their thinking and also in their behavior. As we mentioned before, they're anxious, they're oppositional, they are manipulative, and they do have the skin-picking impulse control things. And this leads us to what we call Prader-Willi syndrome plus. This is the PWS personality plus stress. It could be PWS personality plus an underlying medical condition. And the point of this is that all medical conditions produce stress. So stress may be the final common denominator. Prader-Willi syndrome personality plus a learning disability. These are also bona fide diagnostic categories. And learning disability and intellectual difficulty are two things which we know further limit adaptability, which then produces more susceptibility to stress. And then finally, the Prader-Willi syndrome personality plus a psychiatric condition. And as I've previously mentioned, psychiatric conditions are produced or unmasked by excessive amounts of stress.